Hereby, I open this academic ceremony in which Matteo Nardin will defend the academic thesis, Implications of Genetics and Major Risk Factors on Platelet Morphology, Platelet Aggregation and their relationship with coronary atherosclerosis. I also would like to welcome the promotion team, Professor Van het Hof, a professor of interventional cardiology at the University of Maastricht, Professor Ten Berg, professor of anti-thrombotic therapy in cardiac catheter intervention, also from the University of Maastricht, and co-supervisor Professor De Luca, professor of cardiology at the University of Messina, Italy. May I invite the candidate to present a summary of the study and the conclusions of your thesis in about 15 minutes.
Okay. Thank you, Prorector. Highly esteemed opponents, friends, family, thank you for this opportunity. I'm going to present investigation that we conducted. Several advances has been achieved since the first three cornerstones of thrombotic process were established by Virchow. And in particular, platelets have been identified as key actors in thrombotic process, especially on arterial side of vessel 3. In particular, several mediators have been identified in promotion, the activation, and also the aggregation of platelets that are key elements that will sustain and aggravate the atherosclerotic disease, especially at the coronary side. Therefore, we decided to focus our investigation on this element, on platelets. We assessed the platelet according to two main features, the morphology and their activity. The morphology of platelets could be assessed through the volume that is evaluated through the measurement of mean platelet volume, and also the reticulated platelets that is assessed during daily clinical practice through the measurement of immature platelet fraction. The mean platelet volume is already recognized an important key element of platelet morphology because larger platelets were found containing a higher concentration of arachidonic acid and juice, leading platelets to a higher number of prothrombotic cytokine production. By the way, no definite results have been provided in relation to mean platelet volume to atherosclerosis, especially in general population. Therefore, we focused our research on patients with impaired metabolic situation, in particular patients with metabolic syndrome, and actually we found a higher value of MPV among patients with metabolic syndrome compared to those without. However, after the adjustment for mean baseline differences, these differences was not confirmed. And among patients with metabolic impairment, the MPV values did not predict any, neither the prevalence of coronary artery disease or the prevalence of severe coronary artery disease expressed as left main disease or free vessel. The other parameter related to platelet morphology that we evaluated was the reticulated platelets, because platelets, these are platelets with a higher quantity of RNA, thus leading to a higher quantity of prothrombotic transcript and thus to an enhanced platelet aggregation and reactivity. This value, the quantity of platelet or reticulated platelet in daily clinical practice could be assessed through indirect methods using the immature platelet fraction assay. We focused our research in particular with the relationship between the active smoke and the platelet aggregation, because preclinical studies and also clinical studies enlightened that active smoke is significantly related to acutely platelet aggregation, not only as already known as a traditional cardiovascular risk factor. Therefore, our investigation confirmed that active smokers had a higher value of IPF, even after adjustment for main baseline differences. But among smokers, the IPF value that indicates the quantity of reticulate platelets, the fraction of the reticulate platelets, did not predict the prevalence of coronary artery disease or severe CAD in a population of patients undergoing percutaneous coronary intervention. The second part of the thesis involved the investigation of platelet reactivity, in particular the height residual platelet reactivity, also named the height on treatment platelet reactivity, because this condition is related to a poor outcome in patients receiving antiplatelet treatment, because this condition is related to a residual platelet reactivity despite the treatment with a dedicated antiplatelet agent. Several conditions have been linked to this phenomenon, ranging from genetics also to metabolic impairment to co-drug administration to comorbidity, and also, of course, also patient's compliance. The first factors that we studied was the obesity, because the underlying insulin resistance is directly linked to a chronic inflammatory environmental, especially in a blood vessel, that could promote and sustain platelet aggregation. Therefore, platelet aggregation, and therefore a prothrombotic status. In our cohort of patients admitted for an ACS and on dual antiplatelet therapy to aspirin and clopidogrel or ticagrelor, we assessed the platelet activity through the multiplate impedance aggregometry, and we found a direct relationship between the body mass index and the platelet activity among patients under clopidogrel treatment, whilst in patients with ticagrelor, these findings were not confirmed. And also the prevalence of the patient at HRPR resulted higher among patients with higher BMI among those treated with clopidogrel. The second metabolic factor that we studied was the uric acid, because it is known that the ticagrelor treatment leads to a positive variation of serum uric acid level that actually was also confirmed in our cohort of patients, but this did not translate into a significant variation in the percentage of HRPR, neither between clopidogrel treated nor between patients treated with ticagrelor. Also, co-drug administration has been hypothesized to be linked, to be related to the prevalence of HRPR. In particular, we decided to inquire the potential of co-administration of high-intensity statin that are key elements in post-ACS patients' treatment. In particular, we found that the co-administration of clopidogrel and rosuvastatins could lead to a higher rate of patients at HRPR, and this significant finding was also confirmed at the multivariate analysis. The last issue that we investigated was the pathways of platelet inhibition mediated by ticagrelor, because alongside the already known and well established in platelet inhibition mediated by bindings the P2Y12 receptor on platelet surface, ticagrelor could also block the NT1 transporter on erythrocytes, thus leading to a higher concentration of free serum adenosine, that could inhibit platelets to A2A receptor placed on platelet surface. We inquired a single nucleotide polymorphism of the A2A adenosine receptor that is expressed on platelet surface, and even if we didn't find any differences at platelet function tests assessed at impedance aggregometry, we found that patients in homozygosis for the mutated allele of this polymorphism displayed a lower percentage of HRPR compared to patients that carry the wild-type allele. By the way, I would like to underscore that even if our efforts focus the attention to achieve the most platelet inhibition as possible, we should not forget that this could expose patients to a more pronounced bleeding risk, because it was already established that post-discharge bleeding is one of the strongest predictors of mortality in patients receiving a stent implantation. Therefore, we should still conduce more investigation on platelet activity, because still the latest guidelines released 1 month ago report a gap in evidence about the potential use of platelet function testing or genetic testing to tailor the antiplatelet therapy in patients admitted for NACS. Therefore, alongside the already established pathway of platelet activation and aggregation, the future will for sure involve also the genetic inquirement, in particular not only the polymorphisms that were extensively studied, but also the genetic field of RNA, in particular the microRNA, that is a hot topic under investigation this year, because the miRNA could interact directly inside the platelets, and also by binding on the plasma surface the glycoproteins and the receptors, as well as the genetics, also the central role played by platelets in the crosstalk between the immunity and the cardiovascular system deserve attention for future research to highlight this potential link. My conclusion, therefore, is that despite a higher number of signaling and pathway of activation has been identified and characterized, we have no, so far, a definitive answer for the useful of morphological and functional marker potentially using in daily clinical practice. This could be due, for instance, by the complexity in reproducing in vitro the phenomenon of aggregation that remains a critical challenge. And therefore, I think that the paradigm that guided the research in the last year should be shifted to not from solution that could be valid for everyone to a solution that should be personalized according to the patient that we have in front of us, according to the metabolic and the genetic factors, as well as also the polypharmacotherapy that more complex patient that we treat requires. Thank you for your attention. I'll give the word back to the prorector.
Thank you. We will now open the opposition, and this will be started with the chair of the assessment committee, Professor Kreins, who is Emeritus Professor of Cardiology at the University of Maastricht. Professor Kreins.
Thank you very much, Mr. Prorector. Dear candidate, dear Dr. Nardin, I congratulate you with all the work you have done, and it's more than is what in this thesis. And I also congratulate you with the thesis you have written. And I also think you do a great job because you're working in what I call the new cardiology, which is not on per se on imaging and interventions, but on understanding, in this case, where atherosclerosis comes from, and you choose to look especially at platelets. So congratulations also for that, and I think that's a very good direction, so we can see the new cardiology in 10 years, and this will be in. I've not come to give you a lot of compliments, but to ask questions, okay? And I would like to go to chapter 2. And when reading this, it occurred to me that the endpoint you choose to look at the importance, the impact of immature platelet fraction, that is not quite adequate. What I want to say is if you looked at significant coronary artery disease as an endpoint, just to relate immature platelet fraction to that. Now in hindsight, do you think that is an adequate endpoint to relate immature platelet fraction to?
Thank you for your compliments, highly esteemed opponents, and thank you for your question. In the chapter 2, yes, we evaluated a potential role of the IPF fraction, the IP fraction, the percentage of immature platelets over the total platelet counts, that actually is a surrogate of the reticulate platelets. This is due mainly because the direct measurement of reticulate platelets is difficult to be assessed in daily clinical practice, because the blood sample should be stained with particular substance and fixed to identify platelets containing RNA. Therefore, the IPF assay uses a light fluorescence to identify and interplay with the volume of platelets to identify the fraction. Larger platelets contain a larger proportion of RNA. Therefore, IPF is a surrogate of direct measurement of reticulate platelets. In this investigation, we aimed to evaluate if this parameter, this surrogate parameter, could be a marker of atherosclerosis at the coronary arteries, instead of a predictor of adverse outcome. Our aim was to investigate if IPF could be a useful marker before for the performing a percutaneous coronary intervention, and therefore could predict the presence of atherosclerotic at the coronary artery.
Yeah. Now my point is, does it surprise you that the immature platelet fraction, as you defined, and did not relate to the extent of coronary arteries? Did that surprise you?
Actually, not so much.
Because?
The reason is because it's, well, the role of reticulate platelets should be already highlighted, because I think that in this case, IPF should not be, is better a marker of platelet turnover instead of a marker of the extent of directive of the atherosclerotic disease.
Yeah.
Therefore, could be maybe useful in a follow-up assessment.
Yeah, I understand.
And for this reason, instead maybe on a focused snapshot that we give in this cross-sectional study.
Yeah. Thank you for that. Now, you also relate immature platelet fraction to several clinical parameters, and one of which I was interested in. You explained uric acid, and I understand if platelet count is decreased, then you will have a higher immature platelet fraction, I guess. Huh?
Okay.
But now HB, if the hemoglobin is up, what has that to do with immature platelet fraction? I'm completely ignorant here. I don't know anything about this, and I was intrigued by this, and like to you to tell me, why did you find an increased hemoglobin level in relation to immature platelet fraction?
Actually, I have no an answer to this observation, because the platelet turnover is regulated by several conditions, comorbidities, and so on. For sure, we can maybe find the answer in the next chapter, when we found that active smoker had a higher IPF value. Therefore, the active smokers usually leads to a higher a low grade of inflammation, and then a higher production of erythrocytes from the bone marrow. Therefore, the higher value of hemoglobin related to IPF.
Yeah, that's an obvious. And you could have done an interaction analysis there to show that they interact. But if I may, one final question, Mr. Prorector. There's still time. Okay, thank you. And there's another finding, and that is that you found a relationship with more bifurcation lesions and the immature platelet fraction, which suggests that these immature platelets, I understand, relate to especially initiation of atherosclerosis at bifurcations. Is that what you try to say?
Of course, the bifurcation, thank you for your question. I esteem your point. Of course, in bifurcation lesion, the shear stress is higher. And therefore, it's a critical crossroad of bloods. And in bifurcation, of course, there are a small environmental that is for a physical condition thrombotic, and therefore leads to a higher platelets consuming or activation. And therefore, in these cases, we can expect that.
So what I understand from your answer is it's not immature platelets causing this, but these lesions causing platelet consumption, and then
not the answer could be that, yes, because actually we didn't find a marker of atherosclerosis.
Okay.
But could be instead the reverse through the reverse relationship. Well, a severe CAD or a CAD placed in a crucial point of the coronary tree could enhance the platelet turnover and choose portray to a higher IPF value.
Okay, I thank you very much for all your answers. I'm very pleased with those. I give the floor back to the prorector.
The opposition will now be continued by Professor Monica Verdoia. She's professor of cardiology at the Ospedale degli Infermi in Italy.
Thank you very much, Mr. Prorector. I want first to congratulate with Dr. Nardin for the excellent presentation and his commitment in producing this research, which is very impressive because platelets are a very difficult topic to evaluate, and he produced brilliant results. Despite all these achievements that we have seen in this thesis, we are still experiencing a lot of thrombotic events in patients, and so there is still much we don't understand. So my question is this gap caused to the fact that we are not looking to the correct clinical factors, to patients' matters, or is this related to technical factors? We are not applying the correct tests.
Thank you for the question, and thank you for your kind compliments, highly esteemed opponents. Yes, despite the achievement in our knowledge about platelet activation pathways, we still observed, and also the platelets and the antiplatelet treatment, we still observed the thrombotic events in these patients. Despite the huge literature that shows us that high HRPR is strongly related to adverse outcome. This could be observed, could be explained, because the aggregation phenomenon is more complex than what we can assess in a laboratory. because in laboratory we can assess only a dedicated platelet activation that could allow us to inform if the antiplatelet drug that the patient is intaking produce the expected platelet inhibition. But the majority of our platelet function test and the platelet function test that we use in our investigations, of course, are specifically for a pathway of platelet activation mediated by ADP, by thrombin, by collagen, by aspirin. But it's difficult to have an estimation of the overall platelet reactivity, not only the platelet inhibition operated by the drug treatment that the patients are intaking. Therefore, I guess that in the future, the platelet function test should be matched also with other factors to provide us a more comprehensive overview of the platelet reactivity. Matched, for example, with genetic polymorphisms that we are already known, for example, related to clopidogrel metabolic activation, but also, as we reported, also for ticagrelor, that was a platelet inhibitor that did not show so many genetic impact in the prior studies. Therefore, alongside this polymorphism, also the genetic aspect related to the microRNA will contribute to a complete as much as possible understanding of the platelet inhibition, or the platelet aggregation. And also the immunity status of patients, I guess, because the role in the crosstalk between, especially with neutrophils, at the level of the lesion, atherosclerotic lesion, is pretty interesting because platelet not only acts activating neutrophil and promote the atherothrombotic process, but also activated neutrophils by themselves could serve as scaffolds for platelets, therefore to sustain and aggravate the thrombus formation. And this aspect were not routinely evaluated with the platelet function test that we have, because of course the aim that guided the development of this test was to achieve the platelet inhibition with a dedicated antiplatelet agent, but to a better understanding the complex phenomenon of aggregation, we should take into consideration also other factors.
Thank you very much. If I still have time for a quick question.
Sure.
Thank you very much. Why did you specifically choose this test, impedance aggregometry, rather than other tests that have larger literature or validation?
Thank you for the question. We decided to use this test for several reasons. First, this test allowed us to explore dedicated pathway of platelet activation using specific platelet agonists like ADP, like thrombin, like collagen, and also aspirin, arachidonic acid, sorry. And this different substance allowed us to evaluate the ability to promote the aggregation of platelets according to different stimuli, because we aimed to investigate if there were different platelet reactivity according to the different drug intake. And therefore, we were able to evaluate the specific the presence of suboptimal platelet inhibition according to the single drug type that patient assumed. For example, the pathway inhibition mediated by aspirin was assessed through the addition of arachidonic acid in the blood sample, while the platelet inhibition mediated by P2Y12 inhibitors were assessed by the addition of ADP in the blood test, and also these are the main that we investigate in our works. We didn't actually use the aggregometry, the light transmittance aggregometry that is considered the gold standard to assess for several years to assess the platelet reactivity, because this test, even if it could provide a more finer details on platelet activation, is an in vitro test, because the blood should be prepared, and the test was not performed on whole blood, but is performed in a platelet-rich plasma. Therefore, the blood sample is manipulated, and therefore also the physical condition change, and were different between the condition that we can have in blood vessel in our arteries.
Thank you very much.
The opposition will now be continued by Professor Stefanini. He is Professor of Cardiology at the Humanitas University in Milan, present online.
So, congratulations, because the data that you presented are really interesting, and also you actually presented them very clearly in your dissertation. So I actually have a question which puts your data somehow in perspective. You evaluated very well the role of platelet activation, platelet aggregation in a number, a large subset of patients, and clearly discuss the ischemic implication of these processes, and therefore also highlighting the role of a number of parameters as potential tools to assess the patient's ischemic risk. On the other side, however, you know, not only from your data, but from the literature, that patients who have an intense platelet inhibition are exposed to a risk of bleeding. And often these two risks are pretty much running in parallel, and disentangling the two aspects of these risks is not that simple and obvious. So I'm wondering whether you see a potential role of a number of variables that you have highlighted in your thesis in the application as tools to identify the ischemic risk in patients at high bleeding risk.
Thank you for your compliments, highly esteemed opponents, and thank you for your question, Professor. Actually, yes, you are completely right when you talk about the almost marriage between the ischemic and bleeding risk in especially complex patients, because the advance that we achieved in last year allowed us to treat more complex patients than some years ago, and therefore more complex patients leads to a more complex clinical condition that deserve attention, that these patients were not so many times included in the majority of clinical trials. Therefore, the optimal strategy that should balance the platelet inhibition to achieve the lowest thrombotic risk as possible sometimes determines a rising of the bleeding risk. There are some suggested, also by guidelines, tools to stratify the risk the bleeding risk and the thrombotic risk. There are some clinical scores like the DAP score, the Paris score, and also the ARC-HBR that could provide us a clinical estimation about the thrombotic and the bleeding risk in patients. And according to these tools, guidelines suggested to consider a different time and duration, particularly of dual antiplatelet therapy. In both patients that received a stent implantation after percutaneous coronary intervention and were admitted for a chronic coronary artery disease, and also patients admitted for an ACS. However, also this score were not, of course, perfect, and take into account, in my opinion, mainly clinical variables that, of course, are fundamental, but unfortunately, they could explain us only a proportion of the overall thrombotic risk, because also the latest tools that was proposed, the ARC-HBR system that provide us the bleeding risk in this patient, and therefore should help us to tailor the antiplatelet treatment, has a overall sensitivity ranging around 80%, 85%. Therefore, some patients still does not match the results of these tools, and therefore I guess the residual proportion of patients that still have events, bleeding or ischemic, and does not and is not appropriately identified by these tools, this gap should be overcome implementing other factors that we are not still we could not evaluate routinely because, for example, the microRNAs are pretty difficult to evaluate, but for sure the evidence, the observational evidence of the related to the impact of this small part of RNA, their impact and the relationship that evidence suggests us could explain the differences in patients that still may have a lower bleeding risk, a lower thrombotic risk according to the scores that we use in daily clinical practice, but that will have an event after the PCI intervention. And of course, we, in relation to the immunity, we already have the evaluation of the inflammatory status of patient, like for example the assessment of the neutrophil to lymphocyte ratio, and also the evaluation of the C-reactive protein. But are of course general and useful, of course, tools, but that could not explain all of the issue, all of the events in these patients. And therefore, still in the guidelines, the gap is highlighted in relation to the platelet function test. Therefore, also the platelet function test alongside the clinical score could be improved, also taking into account other variables. Of course, the clinical variables are the easiest to be obtained and to be used to stratify the patient's risk, each patient's risk, but they could not provide us a definite answer. Till date, the score available are the best tools that we have, but are not the perfect one.
Thank you. I'm satisfied by your response.
Next one is the Professor Kedi, who is on site. He's member of the assessment committee and professor of cardiology at the University of Katowice in Poland.
Thank you. It's a pleasure for being here and being invited to be part of this commission. I have to compliment the Dr. Nardin here for the good work he's done. It's been a pleasure reading his book. And you speak a lot about platelet reactivity, and there is a lot of work done on measurement of this. As a clinician and as a researcher, I still don't see this becoming part of routine clinical practice. So what will it take for you to have this being routinely used, and how much will it impact the tailored approach to our patients?
Thank you for your compliments. I estimate upon it, and thank you for your question. Yes, the platelet function tests are not implemented in our clinical practice. I guess both from your point of view and also from our point of view in Italy. This, I guess, in my opinion, the main reason is due that the platelet function tests are different, and there are several kinds of platelet function tests that could be performed according to the methods that the assay uses to evaluate the platelet activity. And therefore, each laboratory and each center could have different methods to assess the platelet activity, and this is a huge limitation in when we want to compare the results of the platelet activity, because if you use different methods to assess, of course, the same thing, but the results are different. There are no studies that can achieve us a definite answer about the comparative results of different methods. And different methods actually in clinical trial provided different findings, because some trials that use some specific platelet function test reported negative results, and therefore limiting the diffusion of this test for a clinical practice to guide and to tailor the antiplatelet treatment. Whilst other trials using different methods actually reported the potential benefits in help clinicians to tailor not only the duration but also the type of the antiplatelet agent in each patient. And therefore some limitation, therefore the different methods of platelet function test, in my opinion, and also the negative results that were presented with and were obtained with some of these platelet function tests. Of course, alongside that, other limitation will involve also the individualized risk thrombotic risk profile, because of course, as we underscored before, platelet function tests provide us a snapshot on platelet activity, but in a blood sample that, of course, will never be like the platelet reactivity inside the vessel. Of course, when we took a blood sample, we remove several conditions that are physiological in our patient. For example, first of all, the endothelium. We don't have the endothelium in the blood sample. Therefore, we remove one of the most important triggers of platelet reactivity. Therefore, we evaluated a single platelet pathway of platelets, but not the aggregation, the overall aggregation. Therefore, we limit our investigation on a single pathway. That, of course, could provide us a useful answer to guide our approach. But we can lose some precious information during this assessment. Therefore, it's difficult, of course, reproduce completely the phenomenon, and I don't have a definite answer how we can overcome this limitation and to have a most complete as possible look of the aggregation in each patient, and also the other factors, the immunity cells, were not considered when we assess the function test, platelet function test.
Okay, thank you. May I have another question? Can I ask one of your paronyms to read proposition number 10?
Proposition number 10. Speak little, listen a lot, and look at the goal of what you do.
And that stays also Chapter House, Chiaravalle Abbey, Fiastra, Italy. So I didn't know where Fiastra, Italy was, so I went to look to that as it's somewhere in Macerata. And my question is, why is this important to you, and why is this statement here?
This actually, when I visited this place with my parents and my brother, I took, I guess, almost 15 years ago, or 20, I don't remember exactly. I took a small souvenir reporting this sentence, and I always took this small souvenir reporting the sentence on my desk, because I think that could be a useful suggestion to guide my approach. In particular, also when I have someone in front of me, in particular patients, because this is my opinion from my limited experience in clinical fields. We should reduce the amount of word that we pronounce in front of patients, and we should listen more from them, and then focus our attention on what we can do for patient. This was my interpretation of this sentence. Of course, I guess that when they wrote this, their aims were different, but I like to interpret it in this way.
All right, thank you. I have no further questions.
Now we will continue the opposition with Professor van Geuns. He's online. He's member of the assessment committee, and his expertise is the interventional cardiology at the Radboud University Medical Center in Nijmegen.
Thank you, Mr. Rector. Dear candidate, I would be interested to have your discussion on your thesis today. At first, I wanted to say it was a pleasure to review the work you have performed. This thesis contains a large amount of original scientific research, and for most of them, you're the lead author. I also want to acknowledge the work of your supervisors in completing this project with a high number of patients, but also, as you just explained, I think several times in the last 30 minutes, the extensive lab works to do that, because you have to be very cautious and routinely expert in that kind of work. In the end, this is the work you have been doing, and I want to congratulate you and your team on this achievement of today. So as part of today's ceremony, of course, I have to have my questions to you, and we have a few minutes of discussion left. Professor Crijns already started working on you with chapter 2 and 3 on the endpoint. Again, you explained how this platelet function, the immature platelet fraction, is important for the patient. But I want to continue a bit on his discussion, maybe on the endpoint, because the patients you kind of selected are, in my way, at the end of the process. So if you want to look at severity of coronary artery disease, why did you select only patients with an angiography who all have 80% at least complaints of angina? So they are at the end stage of, would say, a high extent of disease, all reach the same threshold of coronary artery disease with giving symptoms. Should you, in retrospective, have looked at other kind of patient population, or there are techniques to have a larger variability in your amount of coronary artery disease?
Thank you for your kind compliments. I esteem your opponents, and thank you for the questions. In that studies, the population of reference were all patients that were referred to our cath lab for the assessment of coronary angiography. And therefore, instead of the second part of the thesis that involved only patients that actually received a percutaneous coronary intervention, we included in the platelet morphology studies all patients undergoing coronary angiography, even those that were not planned undergoing any intervention at coronary artery. Therefore, of course, we can consider that the patients, of course, that were referred for a coronary angiography could be at high risk of coronary artery disease to be affected by coronary artery disease. But actually, no negligible proportion of our patients received coronary angiography preoperative, for example, before a valve substitution that were not so strongly so many times related with the coronary artery disease. Of course, this could...
So let me do a suggestion to you and see how do you feel about this, because I think if you want to look at the extent of coronary artery disease, you maybe should better look at the population cohorts. You know, there was an American, the MESA cohort, which had CTs. Also in Rotterdam, there were 2,000 patients, or not patients, just volunteers 50 years plus who had CT. So I would say there you have a much wider distribution of coronary artery disease, and you might find correlation between the immature platelet fraction and the extent of coronary artery disease. Is that a good suggestion for me?
Thank you for that. We will improve, of course.
No, I think hopefully you continue your research, and maybe you can reach out to these groups and to see if they have some blood samples left and to look at the immature platelet fraction. Now, as you mentioned, 20% of your patients didn't have coronary artery disease. They had, if I found somewhere correct, valvular disease or other problems. But still, you do your angiography for a non-interventional cardiologist is pretty simple. It is either severe or non-severe, which is either free vessel disease or less, and a few left mains. Is that not a bit crude? Didn't you want to do more extensive evaluation of the extent of coronary artery disease in this patient population?
Which instrument to evaluate in another way?
I was triggered by the analysis where you found, and also was mentioned by Professor Clance, that bifurcations and CTOs were a bit more prevalent in the high immature platelet fraction patients. These kind of numbers are adding up in syntax score. So syntax score is a considerable more extensive score looking at multiple segments, diffuse atherosclerotic disease, and complex lesions out of bifurcations and CTO. So I would wonder, should you maybe also find a different result if you would do, besides just a crude dichotomical extent, a more continuous scale, which has been validated in many studies?
Be of interest. I should underscore that the first patients are enrolled, I guess the syntax score and other definitions were not available to be defined. Therefore, we didn't stratify the extension of the coronary artery disease according to this issue, to these parameters. And
I would say just a suggestion to keep on going with your research, because you can 2,000 angiographies. It takes some weeks, but you can really do the scoring on that. I want to make a switch if there's some time left or not. I didn't hear the sound, so I see yes. I also learned that you had some previous discussion on the general impact of your research. I think I've learned a lot, and I think that everyone should read these articles, because we really start understanding that platelets have many functions in coronary artery disease, and are important to better understand that. Now, you find all these tests, and that should maybe suggest you to go into personalized medicine. So either do the test or do some other work before we decide to give either ticagrelor or clopidogrel or short or long DAPT. Am I correct that you would really love to do more personalized medicine?
This is my view. In fact, the personalized medicine, I guess, would be the future. And also my mentors always said me that the future will be that we will achieve a solution that will be the appropriate solution for the patient that we have, not for the pathology that we have in front of us. Because we can also obtain a solution that could be drug treatment or interventional approach for the condition, the disease that we have in front of us, but we should shift our view from the disease to the patients, because the patients has other condition, other factors that should be taken into consideration. For example, the polypharmacotherapy. For example, because the vast majority of patients that we have in our wards took for at least 5 different drugs. And this factor is several times, unfortunately, not so well assessed in clinical trial. Therefore, my thoughts is that, of course, we should find the appropriate treatment for the disease we have in front of us, but not only for the disease, because the disease is of a person, and therefore, together with the disease that we are fighting, we should also consider the side effects, the side potential damage, and other conditions that could hamper us to achieve our intent.
That's what I expected you to be your answer. You want to go into personalized medicine, then you showed a slide of the recent ACS guidelines, and their personalized medicine is, I would say, in the depth, etc., is pretty, although they're really good studies for genetics, you just mentioned from your supervisor, the Maastricht from Rotterdam, really didn't bring up to a high level. Is that disappointment, or is there good reasoning by the guideline editors?
Please, could you answer very short?
Yes. Well, I guess the guidelines are still right. We should improve our knowledge and to better characterize how assess the platelet reactivity in our labs. This is.
Let's keep that as the short answer. Thank you, Mr. Rector. Then continue with the discussion.
Okay, we continue the opposition by Professor Tenkate, who's also a member of the assessment committee and secretary of this committee, and professor of internal medicine, in particular hemostasis and thrombosis at the University of Maastricht.
Thank you, Pro-Rector, dear candidate. I much enjoyed reading your thesis as well, and congratulate you with this. And in the remaining minutes, I want to touch on a broad field, plenty of time, because, well, in the discussion, you've been able to give an overarching view, which comes from experience, but also from the fact that you have published quite some papers in this field. That's quite impressive, I would say. So maybe time for 2 questions. Based on the figure that you also showed in the late presentation on page 38, where you depict the interplay between the immune and cardiovascular systems based on immune cells and platelets. So basically, I would like to ask you as a first question, do you think that any of the current antiplatelet agents has any clinically relevant impact on inflammation?
Thank you for your compliments. Highly esteemed opponent, thank you for your question. Actually, I do not don't know actually the answer if any of the antiplatelet, especially the P2Y12 inhibitors that are the cornerstone of the antiplatelet treatment in especially in high-risk population patients admitted for an ACS, because also the latest guidelines could recommend also a monotherapy to P2Y12 inhibitors instead aspirin after the dual antiplatelet therapy. Of course, the aspirin for itself mechanism of action for its pharmacodynamics could produce inflammatory modulation that could not only be, of course, related to inhibition of platelets, but could also involve the inflammation and therefore immunity system.
Yeah,
of
for
course,
example, if I may interrupt you, you mentioned this platelet-neutrophil interaction. The platelet-neutrophil interaction, do you know if...
Neutrophil,
yes.
Yes.
If the P2Y12 inhibitors, for instance, have any impact on those cell-cell interactions?
Not directly to neutrophils, but they could, of course, if the P2Y12 inhibitors could reduce the activation of platelets. Of course, the uninhibited platelets will not produce and will not activate neutrophils, and therefore should allow us a beneficial circle to reduce future the activation of nets, for example. But a direct action on neutrophils, actually, I don't know. Of course, a global inhibition of platelets could, in that particular interplay with neutrophils, could reduce the release, of course, of pro-inflammatory cytokines and reduce the neutrophil activation by platelets.
Are there, second question, 10 seconds.
Okay.
Are there new antiplatelet agents emerging that have more impact on inflammatory processes? Do you know?
In my opinion, no, because the research aimed to focus on a finer action, therefore avoiding side effects on that.
You are allowed to finish the answer.
Okay.
Or not.
Yes, of course. Thank you, Director. I guess that because the research focused on specifically target the dedicated receptor, and also the biochemical engineering will design as much specific as possible drug. I don't think that this will be a possibility to achieve a drug that could act on platelets, on immunity, and on so many targets.
Thank you very much.
In the meantime.
I'm very pleased with the answers.
Matteo Nardin, the time appointed for defending your thesis has passed. The degree committee will now withdraw. To discuss the quality of your thesis and your defense, I request that you and your company await the results of our deliberations and our return in this room.
The PhD defense has now ended. The degree committee will debate the candidate's performance behind closed doors. This process usually takes about 10 minutes.
Long road to the south side. 7 miles in my rearview mirror, I know what it felt like. My goals only getting clearer, east side to the west side. No place like home, if it's questions that you've got, go the extra mile and that. On the line, I know you know that I can't read your mind. Years can't fly by now, the way waste all your time, 'cause I'll go the extra mile. Long road to the south side, 10 miles in my rearview mirror. I know what it felt like. My goal's only getting clearer. East side to the west side, no place like home. If it's questions that you've got, go the extra mile and night. On the dash, got my laces tied. Long road, I don't waste no time. Break rules because fate decides. With the team and we chase the light. I make a move, fall down, shake it off. I hate to lose, bad branch, break it off. No room for negativity, praise and love. Prepare for deep part cause we're taking off. Get the mileage, traveling so far from home. Gathering knowledge, other connections. I put the time in to get everything I ever hoped for. It's a challenge and we all in. It's a better future that we go for. Even though these nights seem long, I know that I am never on my own. Know you've won the battle once you've grown. To the south side, 10 miles in my rearview mirror. I know what it felt like. My goal's only getting clearer. East side to the west side, no place like home. If it's questions that you've got, go the extra mile and night. Long road to the south side, 10 miles in my rearview mirror. I know what it felt like. My goal's only getting clearer. East side to the west side, no place like home. If it's questions that you've got, go the extra mile and night. What's on the line? I know you know that I can't read your mind. Years can't fly by now, don't waste all your time. 'Cause I'll go the extra mile.
Okay.
Matteo Nardin, the degree committee here present has assessed the quality of your thesis and your defense. In view of its positive verdict and taking into account your previous qualifications, the degree committee has decided to grant you the degree of doctor. Professor Van 't Hoff is authorized to confer upon this academic distinction in accordance with Dutch university custom. I invite your supervisor to now take the floor.
Do you promise to work in accordance with the principles of scientific integrity, at all times to be careful and honest, transparent, independent and responsible?
I promise.
By the authority vested in us by law and in conformity with the decision of the committee here present, I hereby confer upon you, Matteo Nardin, the degree of doctor and grant you all rights attached by custom and law. As evidence of this, I now present you with the degree certificates signed by the rector, the secretary and the other members of the committee and affixed with the official seal of the university.
Ladies and gentlemen, Prorector, Professor Van 't Hoff, Professor Tenberg, dear colleagues. First of all, I would like to express my deepest gratitude to Professor Van 't Hoff and the Dean of the Faculty for giving the opportunity to my fellow Matteo to complete the PhD at the University of Maastricht. Prestigious university, one of the best ranked university in the world. I would like to thank all the members of the evaluation committee, the assessment committee, the opponents, some are from Italy, Professor Verdoia and Professor Stefanini. It is a great honor and a privilege to be here today for this thesis defense. It is a great emotion. The first reason is that because 20 years ago I defended my PhD thesis in Groningen under the supervision of Professor Suraparnata and Professor Zelstra. It was the conclusion for me of an important phase of my life, of my career. Was at the end of my fellowship in Zwolle, and Professor Van 't Hoff was one of my mentor, a friend, a teacher. He transmitted me the great passion for research. At that time, I was involved in the on-time trials, and I can say that these trials traced the story of antithrombotic therapy for STEMI. For me, it was a privilege to be in Zwolle. It was a turning point for me that strongly impressed and shaped my character. Being here today, it's a deep jump into the past for me. As in a famous song of the U2, it's dragging the past out into the light. a past that is becoming future, a human chain from Professor Van Toff to Matteo through me. This has certainly made our robust bond of friendship even stronger. The second reason is that Matteo has been for me, as all my students, a sort of bet. It was 10 years ago when an apparently shy and tall student was presented to me by my director. It was at the beginning of the 5th year of medicine. I wanted to attend our division of cardiology to start the internship and to prepare the thesis for the degree of Doctor of Medicine, with the dream to become a cardiologist. And I would have been his supervisor. And it's a sort of funny story I share with friends, but I would like to share with you because my director was a little bit jealous of me. And he tried ways to keep the best students or who he thought were the best students for him. But he didn't know at the time which gift was given to me when he proposed me to supervise Matteo. I quickly understood the great potentiality of Matteo, and I welcomed him in the Novara atherosclerosis study group that was funded by me. He has put a lot of energy during the internship. Unfortunately, he failed to access to our residency in cardiology in Novara. And we were highly disappointed, both of us. A difficult time for him, but also for me, because I was afraid to lose him. He had the opportunity to have access to the residency of internal medicine in Brescia, and without losing the main target, becoming a cardiologist, always putting a lot of energy, passion, and dedication. The first rule in my working group, in my research group, was never give up, and I can say he didn't give up. I told him when one door shuts, another even bigger opens. He's now working as an internist in Brescia at the University of Brescia, but where he completed his residency in internal medicine. But he has started his residency in cardiology in a very big university in Italy, Humanitas, under the guidance of Professor Condorelli and Professor Stefanini, who I'm very pleased took part to the thesis, to the committee. In addition to his tough clinical training in Novara during his internship and in Brescia during his residency in internal medicine, he has spent a lot of energy, time in research. He was involved in the activity of our laboratory of molecular cardiology in Novara, exploring the role of genetics in the tough and complex puzzle of the pathogenesis of atherothrombosis, focusing a lot on platelets, that are, all we know, the most enemy of cardiologists, especially when they work in the cath lab. After he left Novara, I moved to Brescia. Despite the distance, we have been working very closely on our research projects. I had the pleasure to send him to the Mount Sinai to complete a research fellowship for 1 year under the supervision of Professor Meran. We worked together on some projects, very important projects. What to say about Matteo? No words would be enough. I must say that he's one of the most talented persons I've met in my life. He's brilliant. He has a huge willing power. As taught me by my friend, Professor Sina Branata, our goal as a master's is to get the best out of our students or out of our fellows. We should do talent scouting, and a success in our career is when we raise people and let them become faster and better than we are. I gave him the same opportunity I was offered in Zwolle, the opportunity to express all the best we have inside the hidden and the dark cave of our mind. He has published in few years more than 20 manuscripts as a first author. He has co-authored about 100 manuscripts, and many others are under submission, under evaluation. I admire the energy he put in daily practice, the dedication, the passion, the joy, and the humanity with our patients. This is one of the first things I've tried to transmit him and to transmit to my fellows, and I've been very successful. Coronary artery disease is a bad disease with often a great psychological impact. Therefore, our patients need kindness and our psychological support behind what can be the crude treatment. As you know, he has started his residency in cardiology, and that will be completed in 3 years. It was his dream, and it is becoming true. As he says in the thesis, speak little, listen a lot, and look at the goal of what you do. And I think this is sentence in some way is very representative of Matteo. I am strongly convinced that he will do a brilliant career as a cardiologist and as a scientist. I will do all my best to support him, to support his career, and I hope one day we can join together. And let me conclude saying that the beauty of the past is the past. The beauty of the present is that it is a gift. The beauty of the future is that it is full of great and fantastic opportunity to feel good and be happy.
Dear Dr. Nardin, also on behalf of the Maastricht University, I congratulate you with the degree you have acquired. I was struck by proposition number 10. It was already addressed. I think it characterizes you very well. Speak little, listen a lot, and look at the goal of what to do. For today, I would like to make a small variation. You spoke a lot, you listened well, and we looked at the goals you reached. Maastricht, the Netherlands. Before I now close this session, there are some logistical things. We would like to make a picture here with the online opponents. So before we leave the room, we stay here, we come together, and a photograph will taken. And prior to that, I will allow the two online opponents to congratulate you. So I first would like to invite Professor Stefanini to congratulate you now.
Here I am. Well, I really congratulate you, Dr. Nardin. You really did an exceptional job.
Okay, and Professor Van Guns.
Dear Matteo, it was really a pleasure to read all your detailed knowledge about platelets. I want to learn more about it. And also today, you really explained and showcased how much you know about this platelet function. And I think you're one of the top experts in this field. And it was really a pleasure to be present today. Congratulations with the performance today.
Thank you.
Thank you. And I will now close this ceremony.